Good morning, good afternoon, and good evening to all the participants who have come to attend this 388th uninterrupted Zoom webinars being conducted by the International Forum for Promoting Homeopathy. Today's special guest is none other than Dr. M.P. BABU, whom most of the participants know very well as a very eminent and very popular person in the field of continuing medical education. He was very much a wanted teacher for the aspiring students, community, young doctors, and all the practitioners of homeopathy. He was the former teaching faculty chairman of the Institution of Homeopaths Kerala, and today he is coming for the second time. And today his topic is liver diseases and their management through homeopathy. So, with these words, with much pleasure, I invite Dr. M.P. Babu to this auspicious platform. And you are free, Doctor. This platform is yours. I am Dr. C.J. Varghese. Welcome you, sir. Thank you.
Today's topic is hepatology. Hepatology covers almost a major part of the gastroenterology. First of all, we will start with the neonatal jaundice. Actually, I didn't place it in on the slide. We started with the hepatitis, but I wish to start with neonatal jaundice, which we commonly seen in our clinics. There are mainly two reasons behind this. One is the rhesus incompatibility, and the other one is just due to the destruction of RBCs. This is a common thing that we met in neonatal cases. The rhesus incompatibility is nowadays very rare because of this anti-D injection what they are giving, or anti-D immunoglobulin. But even though so, some cases are persisting. Some cases of jaundice are persisting even after administration of these immunoglobulins. I have seen only one such case. The other one is congenital or this newborn infants jaundice, neonatal jaundice. And in both cases, we can successfully treat. Actually, what they say is neonatal jaundice doesn't need any particular treatment, just showing sunlight that will go off, or phototherapy. But even though so, in certain cases, it may get a bit lag. Even after 1 week or 10 days, the jaundiced condition is not coming down. In such cases, I treated a few with 1 or 2 doses of Crotalus horridus 30 and MANGANUM ACETICUM 60. So this is what I have to say about the neonatal jaundice. Now we will go to our main topic, that is the diseases of liver and gallbladder. The common one is hepatitis. As everybody know, it's just the inflammation of liver. The common symptoms are appetite decreased. Maybe there is nausea and vomiting. Nausea is very persistent in most cases. Vomiting is not so. On the second stage, there may develop jaundice symptoms and tenderness over liver region. We can classify the hepatitis into, etiologically, into viral hepatitis, bacterial hepatitis, protozoal due to drugs, toxin and alcohol, and autoimmune. See, in between, I forgot to say one thing. Actually, we are conducting this session on 2 weeks apart. The first session is today. Today, we are dealing with the disease, investigation, and diagnosis. On the second session only, we will discuss about the management. So, whenever a patient comes to our chamber, it's our duty to, as a doctor, it's our duty to diagnose the case first. What's the case? Which organ is affected? So, for that, we must have a very good knowledge about the investigations. So, I am giving more prominence to investigations in this session. So, now we will go to the viral hepatitis. Viral hepatitis means the inflammation of liver caused by viruses. Mainly 5 groups are there: A, B, C, D, and E. We are well aware that A and E are very common and transmitted through contaminated water, while B is through blood transfusion and it can also be sexually transmitted. C is by blood alone. D. So we discussed about hepatitis A. That's the serological investigations. That's a hepatitis A virus IgM antibody and hepatitis A virus IgG antibody. Now we are coming to the hepatitis B. What we do usually is HBsAg. That's what we do. That's a common test nowadays we do prefer, because HBV antibody that may be seen in certain persons who were taken this hepatitis B vaccine. So we depend more upon the HBsAg vaccine. I mean HBsAg test, serological testing, that hepatitis B surface antigen. The other tests are anti-HBs antibody and anti-HBC antibody. As the name suggests, it's HB surface antigen and HB core antigen. Regarding the hepatitis C, the serological investigation is anti-HCV, that's HCV antibody test. And anti-HDV, as I told you earlier, hepatitis D is a version which is commonly seen in B patients only. There is no independent disease diagnosed with D. And anti-HEV for hepatitis E and A and D are very common. Here we do anti-HEV IgM antibody and anti-HEV IgG antibody. This will help us to diagnose the viral hepatitis. The other cause is bacterial hepatitis. This also usually presented as acute hepatitis with jaundice and other symptoms as we described earlier. The considerable difference or the change what we can see is almost all the viral antibody tests are negative in this one. And when we look in the CBC, there will be increased ESR. There is not much change in the ESR when in viral hepatitis. But in bacterial hepatitis, the ESR is usually seen very much raised. The other one is liver abscess. Then chronic granulomatous hepatitis, pyogenic abscess, mainly due to enteric bacteria like E. coli and Klebsiella. These are the 2 varieties of bacteria which commonly causes bacterial hepatitis. But in Kerala, even though it's not very common, we can see leptospirosis or Weil's disease. This is also due to bacteria. The serological testing is for leptospira antibody, IgM and IgG. The next one is protozoal. Usually it was infection by Entamoeba histolytica. Nowadays it's very, very rare. The common test is amoebic serology IgG. Other parasites which can cause liver infection are Plasmodium and Leishmania groups. The next one is hepatitis due to drugs and toxins. As we know, continuous use of certain drugs can damage liver cells. Example is paracetamol. Even a paracetamol continuous use can cause hepatic damage and liver toxicity. Liver toxicity due to natural, domestic and industrial toxins or drugs are very common and are termed as toxic hepatitis. The common investigations to be done are 1. CBC ESR, 2nd LFT and antigen antibody screening. Next one is ultrasonography. So these are the acute infections. How to diagnose, how to investigate and diagnose acute infections of the liver. Now we will go to the chronic liver diseases. This is a very, very common disease nowadays, lifestyle disease. As a lifestyle disease or due to faulty metabolism, that nowadays we are seeing a lot of cases of chronic liver disease, especially the CLD, and the management or treatment in modern medicine is very, very restricted. Except supportive measures, they cannot offer anything on this field, and our field actually, or our scope on this field is very high. I have treated a lot of cases, CLD, including NAFLD and ALD. So we will go to this session of chronic liver diseases. Any disease of liver which causes a progressive destruction of the liver parenchyma is known as chronic liver disease. Or we can say any disease which are progressing in nature and are there for more than 6 months. We can term it as CLD, that's chronic liver disease. Here, the pathophysiology is initially there is an inflammation of the liver parenchyma followed by necrotic changes, destructive changes, and later formation of scar and fibrotic changes causing shrinkage to liver. The types, as I already mentioned, it's viral, especially in viral hepatitis, the B and C is a progressive type of infection. It's used to get continually affect the liver and progresses to the destruction of hepatocytes, later leading to cirrhosis. So the first one is viral, second one is NAFLD, that's non-alcoholic fatty liver disease. It's nowadays very common due to faulty metabolism and commonly seen in obesity and patients who are affected with the diabetes due to dyslipidemia, etc. The other one is alcoholic liver disease. As we know, it's due to continuous consumption of alcohol and drugs and toxin. As I already discussed, it's because of some drugs continuous use. Stages, broadly we can divide it into 2 groups. Once it is progressed to chronic liver disease, that's one is compensated or asymptomatic, and the second one is decompensated. In compensated liver diseases, there will not be much presenting symptoms. We cannot see this jaundice, we cannot see any other complaints. The patient is usually very lively and working. There won't be any other symptoms. By an accidental or due to some other reasons, if we take a LFT or USG, then only we can find out that so the person is suffering from CLD. Decompensated liver disease, it's also initially it was compensated one. On a fine morning, there may develop certain symptoms, due to the CLD in the background. That sudden worsening of the underlying disease. Usually, the first symptom may be, in some cases, acute development of jaundice, yellowish skin or yellowish sclera, something like that. Or maybe due to esophageal varices, there is hematemesis on a fine night after dinner and all. When the patient sleeps, he coughs up a lot of blood. When we go and do the test or investigations, we find out that the person is having esophageal varices grade 1. Grade 1 won't cause bleeding. Grade 2 also. Grade 3 and 4 is usually causes breakage and bleeding. And the other symptom is portal hypertensive PHG, portal hypertensive gastropathy. That's another symptom or another condition in which the vessels inside the gastric mucosa are enlarged or distended, and they may cause mild erosions inside, cause bleeding. In certain cases, there won't be any symptom at all, because it's only the presence of occult blood in the stool is the main diagnostic feature. The patient may be losing blood without knowing, and a persistent anemic condition may lead us to doubt this. And on USG, you can see that his liver may be shrunken and fatty changes are there. This is a common findings. And the third stage is when the CLD becomes ESLD, end-stage liver disease. When it becomes the end-stage liver disease, that develops the ascites, encephalopathy, hepatorenal failure, etc. So the early symptoms are jaundice due to chronic inflammation, maybe, not sure in all cases, it may or may not be there. If there is severe jaundice, there may be itching or icterus, and nausea and vomiting, it may be there. I have seen cases without presenting these symptoms. Hepatomegaly in the earlier days, followed by hepatic shrinkage or cirrhosis, then jaundice, weakness and weight loss, portal hypertension, portal hypertensive gastropathy, as I already mentioned, then vomiting of blood, melena. Complications include the ascites, spider nevi, caput MEDUSE. For the freshers, I am just placing the picture of spider nevi. And this is caput MEDUSE. In the abdominal region, the blood vessels are very much enlarged and protruded. Now we will go to the pathophysiology of CLD. Both alcoholic liver disease and non-alcoholic liver disease, the basic phenomena happening is a kind of steatosis. Steatosis means accumulation of fat molecules in the liver cells, leading to steatohepatitis. The continuous accumulation of fat inside the liver cells can lead to inflammation of the liver cells, which causes necrotic changes, followed by fibrotic changes. And these fibrotic changes cause occluded circulation, which leads to destruction of the liver cells and scarring, later to shrinkage of liver and liver cirrhosis. NAFLD, or the non-alcoholic fatty liver disease, is mainly due to metabolic errors such as obesity, insulin resistance, hyperglycemia, and hyperlipidemia. Diagnosis can be made by blood test, as I already mentioned. The blood tests include liver function test, FBS, PPBS, and HbA1c, and lipid profile, serum lipid profile, to find out the dyslipidemic conditions. The next one is imaging techniques. Imaging techniques, usually we use the USG ultrasonography and CT, and in later or very well developed cases, to find out more, we may depend upon MRI. Then biopsy and histopathological examination. Nowadays, we use two kind of methods. One is EUS and the other one is ERCP. EUS means endoscopic ultrasound scan. That's a common procedure nowadays they conduct to find out more regarding this cirrhotic condition and other damages happen to liver, and if there is any obstruction, if the damage is due to any obstruction or anything like that. It's not done in common NAFLD and alcoholic liver disease. If it is usually done in cases of extrahepatic reasons, to rule out any extrahepatic reasons. See, mainly there are two types in hepatology. The hepatic damage is mainly due to intrahepatic as well as extrahepatic. The extrahepatic reasons, to find out the extrahepatic reasons, we do depend on this EUS or ERCP. Very recently, the ERCP is also overcome by MRICP, that magnetic resonance imaging cholangiopancreatography. ERCP is endoscopic retrograde cholangiopancreatography. These are the imaging techniques we use. The common blood tests include CBC, ESR, serum bilirubin levels, SGOT, SGPT, and SGGT, serum gamma GT. And the SGOT, SGPT ratio also of very importance in differentiating between NAFLD and ALD. The other one is alkaline phosphatase. Then serum proteins, hypoalbuminemia, and serum electrolytes, hyperchloremia. This pH of the blood, it ranges from 7.35 to 7.45. It's a very subtle level. A tiny change or a subtle change in the mechanism of this elimination of waste materials or metabolic waste materials can result in change of the pH of blood, leading to either acidosis or alkalosis. In alkalosis, there is usually the reason we find is hypoalbuminemia, and in acidosis, hyperchloremia. And ABG, arterial blood gases. Then PT-INR, serum creatinine urea. Then tumor markers to rule out HCC and cholangiocarcinoma. The tumor markers we depend more on AFP, CA 19.9 and CA 125. Next one is MELD score. MELD score is a novel method to find out in what stage the patient is actually. And I use it as a index to monitor the progress of our treatment. Actually, the MELD score is assessing the severity and prognosis of chronic liver disease. It's mainly based on 4 readings, that serum sodium, serum creatinine, serum bilirubin, and INR. A MELD score more than 12 is considered chronic liver disease or just going towards CSLD, ESLD, end-stage liver disease. And they consider it as a mark for liver transplant. Nowadays, liver transplant is, even though we cannot say it's very common, but it's very routinely doing it. For early stage of cirrhosis also, they are suggesting liver transplant, early liver transplant. So they made a cutoff mark of 12 as MELD score as 12 to fix it, whether to do liver transplant or not. But in our case, we use this to measure the progress of our treatment, how far it is affected. By giving our medicines, I have seen cases which came gradually, the MELD score came down gradually. The another test is FIBRO test. FIBRO test is also another biomarker to assess the degree of liver damage, but not so widely used. It's not prevalent in India. I have seen this case from case came from New Zealand, I think so. New Zealand. There they tested this one, and this is for the first time I came to my attention from their case reports. And it's calculated by using blood serum levels of 5 biochemical tests, namely A2 macroglobulin, haptoglobulin, apolipoprotein A1, bilirubin, and gamma G. I think you know everyone the details of these things. Next one is BONACINI score. This is just for academic interest. It's based on platelet count, SCPT-SCOT ratio, and sorry, it's SGOT-SCPT ratio and INR score. Imaging techniques we already discussed. The fibroscan. Fibroscan is also known as transient elastography, used to assess early fibrotic changes. Now it's used in very big hospitals where there is a good gastroenterology department. Usually they do this test in hepatitis B and C patients to find out the progress of liver disease, to assess the changes happen to liver, the fibrotic changes happen to liver. I think they do it almost in every 6 months. In ultrasonography, it measures the sound waves, echo of the sound waves, but here it measures the wave velocity. Now we will go to the complications. The most common complication is esophageal varices. It's because of portal hypertension due to occluded vessels in the livers, inside the tiny vessels which is occluded by the scarring process. The circulation into liver is diminished, which leads to back pressure and dilation of portal vessels, leading to portal hypertension. This portal hypertension may result as portal hypertensive gastropathy or esophageal varices. Esophageal varices can be graded according to their dilation, namely grade 1, 2, 3, and 4. Grade 1 and 2 are usually silent. From grade 3 onwards, there is chances of breakage and chances for melena, as well as hematemesis and melena is very common. And the other one is decreased platelet. The decreased platelet is due to the defective production of the hormone or the enzyme thrombopoietin produced by the liver, and which causes diminished platelet contents in the blood, and this enhances the bleeding tendency. Once the small vessels inside the gastric mucosa breaks, there won't be any clotting process progressively happening because of the decreased platelets. The other one is hepatorenal involvement leading to hepatorenal syndrome. Then metabolic acidosis. Due to the damage happened to the metabolic errors, metabolism, there will be chances to develop acidosis, especially prerenal azotemia. And due to this prerenal azotemia, there will develop a condition of metabolic acidosis, which will lead to hepatic encephalopathy. The other one is ascites and anasarca. Now, the other cases we met, even though it's not so common, we met in our clinic are Gilbert syndrome. It's a genetic disorder characterized by increase in levels of unconjugated bilirubin due to a defect in processing bilirubin by the liver. Usually seen in adult, mostly accidental finding on routine test. Usually it won't create any symptoms or it won't cause any symptoms. Not a serious condition, no definite treatment is there or required. They have no definite treatment for this, but we do have, and we can treat this. In certain cases, there may be recurrence. for first 1 or 2 years, but later that it's not seen. The other one is Wilson disease. Wilson disease, another genetic disorder inherited by ATP7B gene. A person must get mutated genes from both parents to get affected. Excessive accumulation of copper in brain and liver. Symptoms are chronic hepatitis, swelling of legs, walking problems, brain and nerve discoordination and involvement and discoordination. Then dark brown ring around iris, known as Kaiser-Fleischer rings. Ceruloplasmin. To differentiate Wilson disease from other disease, the investigation is for serum ceruloplasmin levels. The normal level of ceruloplasmin is 20 to 35 mg per deciliter. When these levels are very low, then we can assume it's a Wilson disease. In Wilson disease, ceruloplasmin is very less. Ceruloplasmin is an enzyme which helps to which prevents the accumulation of copper or enhances the metabolism of copper and elimination of copper. The most common remedy is chelidonium. In crude doses, chelidonium is hepatotoxic and causes inflammation and injury to the liver cells. In homeopathically, it's indicated in acute hepatitis with mild to moderate elevation of the bile pigments and liver enzymes. Researchers have shown that it is very useful in acute cholecystitis, cholangitis, and cholelithiasis. In early symptoms of the hepatitis, when the serum bilirubin levels are less than 5, in such cases, chelidonium is very much indicated if the symptoms agree. Even otherwise, chelidonium in low potencies acts on the liver and reduces the jaundiced condition and may bring back the patient to normal within few days. The other one is CHIONANTHUS. CHIONANTHUS is mostly used in jaundice with or liver complaints with the GB calculi or this cholelithiasis. Associated pancreatic involvement or complaint is a sure shot indication for it. Usually in certain cases of this GB calculi or cholecystitis, cholelithiasis or cholecystitis, because of the involvement of this CBD, the inflammation may reach up to the ampulla of Vetter and slowly invades towards the pancreas. And in such cases, there may be an elevation of serum amylase levels also. And in such cases, CHIONANTHUS CHIONANTHUS is more indicated. As it was not in the PowerPoint presentation, I forgot to mention these extrahepatic disorders. Can we say a few lines about that? The most common extrahepatic disorders. The most common extrahepatic disorder is choledochal cyst. Choledochal cyst is nothing but the cyst present in the bile duct, whether it is in the hepatic ducts or in the common bile duct. It's a congenital condition. It's a mechanical complaint. There is not much scope for us in that field. The second one is cholelithiasis. Cholelithiasis is calculi formed in the bile ducts, usually in the CBD, and it can cause obstruction in the CBD leading to jaundice. In such cases also, we have some medicines, especially this Plumpamate and BERBERIS can do a lot. I have treated only 1 or 2 cases in such a case, and symptoms were almost relieved. and the further scannings, ultrasonography didn't show any obstruction of the CBD due to calculus. The third one is XGC, xanthogranulomatous polycystitis. It's a rare condition. I have met only once. It's a rare type of disease where the obstruction of cystic duct as well as the hepatic duct happens due to xanthogranulomatous changes inside the ducts. There, a kind of fatty changes along with granulomatous changes are developing, and it, in certain cases, it almost occludes the entire hepatic duct and cystic duct, leading to jaundice and other painful symptoms. The another one is actually MERSI syndrome. What I have seen is MERSI syndrome. MERSI syndrome is also a rare phenomena. It's nothing but a stone occluded in the cystic duct. You know, the cystic duct is the entrance point towards the lumen of the gallbladder, where there is a almost big calculi which obstruct the cystic duct, and because of the pressure, the hepatic duct also got obstructed, and because of that, a severe form of obstructive jaundice develops. These are the cases just I mentioned here because I have seen cases. There is nothing much to do in this case for us because it was a purely mechanical complaint and the obstruction is so large, it has to be removed. Just I mentioned it for academic purpose. Now we will continue with the medicines. Next one is China. Hepatitis with fever paroxysms. That's a commonest symptom we see. And weakness prominent. Decreased appetite and flatulence. Tympanic abdomen with a sensitive hypochondria. I have seen China is very useful in cases where in cirrhosis patients, advanced liver cases patients where there is anemia, severe anemia persisting due to this hemolytic tendency or increased destruction of the RBC happening. In such cases, China does wonderful results along with MANGANUM ACETICUM. These are the two remedies indicated here. One is MANGANUM ACETICUM and the other one is China, especially in anemia of liver origin or due to chronic liver disease. KALMEGH. KALMEGH is very much useful in hepatitis where the acute hepatitis in acute hepatitis where there is serum bilirubin levels which are moderately high. That's beyond 5 or 6. In such cases, KALMEGH is more indicated than CHELIDONIUM. Say more than 7 milligram per deciliter. In such cases, KALMEGH is more indicated. It's a good medicine for liver diseases arising from the toxicity of drugs. Clinical studies also verified it, that the paracetamol toxicity can be reduced by using Andrographis paniculata or KALMEGH. So in toxic-induced liver injuries or toxic-induced liver CLD, KALMEGH is of great use. It's a good detoxicating agent and helps to reduce increased enzyme levels and brings the hepatic tissues to normal. MYRICA. This is another common drug we use in our practice, but the role of MYRICA is mostly in, I used it mostly in malignant jaundice or hepatocellular carcinomas. Researchers have shown that the principal alkaloid myricanone have apoptosis promoting property or ability and thus controlling the growth of tumors. In HCC, the tumor size can be controlled by using this MYRICA. Another medicine, PHYLLANTHUS neruri, recently proven and now available with almost all pharmacies. It's a traditional medicine widely used in Kerala and Tamil Nadu, parts of Karnataka. In our native language, what we call it as Kidarnelli. It's a very good medicine, PHYLLANTHUS neruri. It acts as a liver tonic and enhances the antioxidant properties and thus prevents the damage to liver. Recent researches on PHYLLANTHUS neruri shows the lipid peroxidation properties in liver, and it reduces the lipid peroxidation properties. By lipid peroxidation, or by the process of lipid peroxidation, actually the fat molecules are added up in the hepatocytes. PHYLLANTHUS neruri have the power to reduce that lipid peroxidation process, thus by lowering the can bring back the fatty changes happened in the hepatocytes or in the liver. So it's very much useful in fatty livers and early stages of NAFLD, non-alcoholic fatty liver disease. Another medicine is Cardus marianus, also known as Silybum marinum. Nowadays, modern medicine is using a medicine namely Silimarin. The Silimarin is actually an extract of our age-old famous Cardus marianus. Cardus marianus contains mainly three alkaloids, the silibinin, isosilibin, and chelidonium. The silibinin exhibits pharmacological properties in liver, particularly in fatty liver, non-alcoholic fatty liver, or NAFLD, steatohepatitis, and a good supportive medicine in ALD. They are giving this medicine to arrest the progress of cirrhosis. Silimarin tablets. Evidences show that hepatoprotective effect of Cardus is by its antioxidant properties and the ability for toxin blockade at the membranous level. Moreover, it enhances protein synthesis and shows anti-fibrotic activities. As we discussed earlier, the changes in liver due to chronic fat accumulation or fatty liver changes is mainly due to the scarring of the hepatocytes or fibrotic changes. Cardus marianus have the property to reverse or resolve the fibrotic changes. Homeopathically, it is indicated in second and third stages of CLD. It's also very much useful in cases of cirrhosis with portal hypertension and esophageal varices. It can arrest the progression of fatty liver to cirrhosis by preventing fibrotic changes. In early case of cirrhosis, which comes to our clinic, then we can daily use this medicine to prevent further progress of the disease. Next one is BERBERIS vulgaris. The effect of BERBERIS vulgaris is on the hepatocytes. It dilates the small ducts or the biliary radicals inside the liver and promotes free flow of bile, along with it can make the bile more fluid. These are the properties. The researchers have shown that. I have the report regarding this. I forgot to add the details because I thought this part will be presented by next week only. So I thought I'll later add. And it enhances bile secretion. Initially, it dilates the small biliary radicals or intrahepatic biliary radicals and promotes the secretion of bile. It renders the bile more fluid. In that way, it's of very much use in gallstones or polylithiasis, because it enabled the more fluid bile to dissolve the calculi formed in the GB. And moreover that it has the properties to dilate the CBD and to remove the obstruction caused by calculus. That's cholelithiasis. It's a number one medicine for to be used in cases of cholelithiasis or CBD obstruction with calculi. Next one is HELLEBORUS. HELLEBORUS is actually used in the late stages of CLD or ESLD, end-stage liver disease, where metabolic acidosis develops. Due to pre-renal azotemia, there develops metabolic acidosis and causes brain involvement, namely hepatic encephalopathy. And the symptoms is presented as stupor, coma, labored breathing, and maybe ascites and anasarca. When we administer HELLEBORUS, then it establishes urination and diarrhea and thereby reduce the acidosis condition, and the patient will come back from the encephalopathy. Another medicine is LEPTANDRA. In our materia medica, it's very much indicated for black tarry stools. It's written as black tarry stools. That we have to find out each and every medicine in this way, where it is useful. Here the LEPTANDRA is useful in ESLD, end-stage liver disease, when there is either the esophageal varices are breaking up, or due to portal hypertensive gastropathy, there is leakage of blood into the intestines, which is presented as melena and mixed with fecal matter, giving a color of black discoloration or black tarry stools. In such condition, there comes the use of LEPTANDRA. Due to reduction in platelets and varicosity, gastrointestinal bleeding is very common in advanced cirrhosis. Melena is the common symptom. Black tarry stools. Here, LEPTANDRA does wonders in this stage. I have clinically verified this in cases. It is also useful in renal cases when there is uremic ulcers developed in the gastrointestinal tract, which causes bleeding and melena. There is uremic ulcers due to persistent uremia. There also develops this ulcerative tendency in the gastric mucosa as well as in the first part of the duodenum, and that also causes this internal bleeding leading to melena. In such cases also, LEPTANDRA is very much useful. Another medicine is LIATRIS SPICATA. LIATRIS is also useful in ESLD, progresses to hepatorenal syndrome, and there develops generalized edema with severe oliguria or anuria. I am giving more importance to the end-stage liver disease medicines because absolutely there is no treatment except management in the modern medicine. In such cases, what they do is they give simply laxatives and life-supporting measures and wait whether the patient is getting back or not. This is a common phenomenon. But in such cases, we have wonderful medicines. And by using these medicines, we can bring back the patient. I had tried these two medicines, namely this HELLEBORUS and LIATRIS alternately in 2 or 3 cases very successfully and brought down the encephalopathy. It's my personal experience. Here, LIATRIS established urination and thus reduces edema. Alternating HELLEBORUS 30 and LIATRIS 3x in hepatorenal syndrome had given considerable improvements in patients' general state and altered sensorium. It's from my personal experience. The other medicine is TELIA, more indicated in chronic hepatitis. Increased appetite is a prominent symptom. Pain in right hypochondrium ameliorated by lying on painful side and aggravated by lying on left side. This is a very much indicated symptom, and most often I verified it. In usual medicines or in usual conditions, the liver complaints, those who are suffering from liver complaints, when the person lies on right side, they will have more discomfort. But in TELIA, it's exactly the opposite. When they lie on right side, they feel more comfort, and there is aggravation in the aggravation from lying on opposite side. I have seen cases with these symptoms. The other major symptom is hepatic symptoms involved with splenic complaints. In certain cases of this cirrhosis or early hepatomegaly, there may be associated with splenomegaly. And in later stage of cirrhosis also, there may be mild splenomegaly can be seen. What we say, it's a splenic dump. And in such cases, TELIA is very good. And the most important concomitant symptom is liver complaints associated with pain in extremities. We cannot say exactly what it is or why it is, but the liver complaints associated with especially lower extremities pain. In such cases, TELIA is very much useful and used to reduce the pain as well as improvement in the patient's general conditions. Next one is APOCYANUM. APOCYANUM, everybody knows. It's a very good medicine for anasarca and ascites. It's a common medicine used by everyone. There is two kind of active ingredients. One is apocyanin and the other one is cymarin. It's more indicated in cardiorenal syndrome. When the hepatorenal syndrome progresses and there is changes in the cardiac functions, then it comes to use. The pumping of the heart diminishes, leading to a kind of LVF, left ventricular failure, which causes pulmonary edema and pulmonary effusion in certain patients with this hepatorenal failure. In such cases, APOCYANUM is more indicated.
Please, sir, kindly help us to know about the disease, the polycythemia and the thalassemia. How the medicines support the liver in homeopathic science to help to get rid of the polycythemia, if it is possible. And second, you have told about a test in the FIBRO the transit elastography, that wave velocity, which helps to judge the liver condition. That wave velocity, how it indicates or guide us the health of liver. This is the thing. And number 4, you have also told about the MELD, the model for liver end disease. So you give the calculation of sodium, creatinine, and bilirubin. Sir, what is the level of sodium in that? And but I feel, sir, regarding today's session, I have a lot of questions to ask you, sir. But I feel that the next coming week is totally we needed from you, sir.
In polycythemia cases, I start with a dose of carcinosin 200. And after 2 weeks, I give a dose of cifilinum tannum. And Ferromet 200 once in 2 or 3 days, a few doses. In most cases, it reversed the condition and made it to normal. Even increased hemoglobin levels are also came down by this. This is a protocol I use. And the second question, I think it's about the fibroscan. In ultrasonography, we gave sound waves and measured the echo produced by the sounds. There is, we may have seen the reports isoechoic, hypoechoic, and hyperechoic in USG reports. Isoechoic means what the sound waves transmitted, the same vibration or the same, say what we say, hertz. That's the measurement of this sound. Those same hertz is returned. That's isoechoic. Hypoechoic actually happens in liquid substance or liquid filled substances, where the hertz of some of the hertz given to that area is absorbed by the fluid, and part of the sound waves is just coming back as a reflection.
Right.
That's hypoechoic.
Okay. Okay.
Hyperechoic is like something stony hardness. If
Yes.
an organ is hardened, then the
Yes.
waves, sound waves sent to that organ echoes in a very high manner.
Yes.
That is hyperechoic.
Okay.
In that way, the USG is verified or calculated
Yes.
by measuring the sound echo. But here we are passing a wave. It can be a sound wave. But here it measures the velocity which comes back. Say, suppose we are sending a particular wave with particular velocity, how much it lost, how much it retained, how much it gives back. It's a measure of that. More details I'm not familiar. This is the preliminary things done there. By assessing the returning wavelength, we measure whether the fibrosity is intensified or increased. Once the fibrotic changes is increased, it will give more waves or more wave velocity. It will very fastly come back. Yeah, total ion binding capacity, when it's very less, TIBC is very less, it's better to give a dose of syphilinum in 1 and follow it with ferrum muriaticum. I use ferrum muriaticum 6C.